Good morning. Welcome back to Open Med School. I'm Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I'll be discussing Internal Medicine Competency 1.8 Pathogenesis and Development of Arrhythmias in Heart Failure, focusing on atrial fibrillation. The learning objectives at the end of the session, you should be able to describe mechanisms linking heart failure and arrhythmias, explain development of atrial fibrillation and heart failure, understand the relationship between heart failure and atrial fibrillation, apply knowledge via some concept questions, clinical MCQs, and assertion reason items. So as we know, the atrial fibrillation, the pulse is irregular like this. This is a normal sinus rhythm, and this is due to the re-entry circuits occurring in the left atrium, especially around the pulmonary veins. We'll go to the main concept. Arrhythmias, particularly atrial fibrillation, are both cause and consequence of worsening heart failure. That is, atrial fibrillation leads on to heart failure leads on to atrial fibrillation. And again, remember, atrial fibrillation occurs in up to 30 to 50% of patients with chronic heart failure and is associated with increased morbidity and mortality. Why arrhythmias are common in heart failure? This is due to structural and neurohormonal changes that is occurring which promote arrhythmogenesis. What are the common mechanisms? One, the most important for atrial fibrillation is the atrial dilation. When the atrial diameter becomes more than 4.5 centimeter, invariably atrial fibrillation occurs. This is especially very common in mitral valve disease. Second is fibrosis. Third, inflammation occurring. Fourth, electrolyte imbalances. These are the major causes for development of arrhythmias in heart failure. So, atrial fibrillation in heart failure, let us see the pathogenesis. One is most important, atrial dilation, which causes re-entry circuits. Fibrosis and remodeling disrupts the conduction pathways. Neurohormonal activation, elevated catecholamines promote ectopy. Diastolic dysfunction produces LA pressure elevation, that is when the ventricles are not compliant, and that is what is called the diastolic dysfunction. So this leads on to increased left atrial pressure. Ischemia and inflammation contributes to electrical instability, and the RAS activation promotes fibrosis. This has been discussed earlier. Atrial fibrosis driven by pressure overload and neurohormonal activation is central to atrial fibrillation development in heart failure. So, two important mechanisms. One is the atrial fibrosis, which is produced by the pressure overload, and neurohormonal activation, especially the RAS activation, is central to atrial fibrillation. Let us go into a few questions. Which structural change in heart failure most predisposes to atrial fibrillation? I request all of you to write down the answer before continuing. So let us. The most important cause is, as mentioned, is LA dilation. When the left atrium is dilated, classical example is mitral valve disease. I already mentioned the diameter increases more than 4.5 centimeters. Which neurohormone is most involved in arrhythmogenesis in heart failure? The correct answer is norepinephrine. Well, one or two assertion reasoning questions also. Assertion: atrial fibrillation is more common in patients with diastolic heart failure. Recent diastolic dysfunction leads to elevated LA pressure and atrial remodeling. So the assertion is atrial fibrillation is more common in diastolic heart failure. We already mentioned that when the LA pressure is one of the cornerstones in development of atrial fibrillation. So the rise in diastolic heart failure, the left ventricle is not functioning properly, not compliant, so the LA pressure increases. So its assertion is correct. Diastolic resumption leads to elevated LA pressure and atrial remodeling. It is correct. So answer is A. Both assertion and reason, that is the R explains the reason, explains the assertion. Next is assertion: electrical remodeling of atria is reversible if sinus rhythm is restored early. That's the correct answer, or the assertion is correct. Electrical remodeling of the atria is reversible. Reason is mentioned is atrial fibrillation leads to persistent atrial fibrosis. This is not a correct explanation. So assertion is correct, reason is wrong, because atrial fibrillation leads on to long term changes and it is not a reversible thing. So we'll go to one case. A 72-year-old man with ejection fraction 30%. So ejection fraction 30% means the patient has got a heart failure with reduced ejection fraction or a systolic failure. He is presenting with worsening dyspnea. ECG shows atrial fibrillation, the heart rate at 140, BP 90. What is the next best step? So the patient, the AF, the management here, cornerstone, the important points are: one is the rate control, second is the rhythm control, and third is anticoagulation. And rate control is more important than the rhythm control. So the correct yesterday the BP is little low towards lower side. So correct answer is administration of. Please note down your answer before continuing. Administer IV amiodarone. Oral digoxin can be given, but the oral digoxin is not effective. Electrical cardioversion only when you know the duration acute you can go for. Again, start a beta blocker. Again, it will take time. In acute decompensant heart failure with AF and hemodynamic instability, rate control with IV amiodarone or cardioversion is recommended. Cardioversion in acute cases, for example, with myocardial infarction, developing AF, you may go for a cardioversion, especially when there is a hemodynamic instability. So let us go into the bidirectional relationship of heart failure and atrial fibrillation. That is, what is meant by bidirectional? Atrial fibrillation worsens heart failure and heart failure promotes atrial fibrillation. So atrial fibrillation worsens. What is the reason? Around 30% of the left ventricular filling is with atrial kick. So when the atrial kick is lost, LV filling is impaired. So naturally, and the irregular rate, the cardiac output is for the fast and irregular rate, the cardiac output is decreased. Tachycardia can lead on to tachycardia or myopathy. So that is the reason AF worsens heart failure. Again, heart failure promotes atrial fibrillation because LA pressure increases dilation of the left atrium, that leads on to development of atrial fibrillation. The RAS activation produces fibrosis and remodeling, that also promotes atrial fibrillation. There is increased catecholamines. Heart failure, one of the supporting system is the sympathetic nervous system stimulation. So this leads on to development of ectopy. So that is why the heart failure promotes atrial fibrillation promotes heart failure. Atrial fibrillation heart failure causes loss of atrial systole, which we have mentioned, which is especially detrimental in patients with impaired ventricular contractions. So the pulse, atrial dilation and fibrosis, key drivers for AF in heart failure. AF more common in heart failure with preserved ejection fraction due to LA pressure elevation, which we have discussed. Assess hemodynamic stability before deciding rate control versus rhythm control. IV amiodarone and digoxin are preferred in acute heart failure with atrial fibrillation. Sinus rhythm restoration improves quality of life and outcome, about which we will discuss later. In the next session, we will discuss about the role of digoxin and how to manage atrial fibrillation. Again, remember that there are other causes for atrial fibrillation. In heart failure, there can be thyrotoxicosis may be the cause for atrial fibrillation. So remember these things also. Thank you.